next presentation is insulin dependence is associated with poor long-term outcomes but equivalent perioperative outcomes following abdominal aortic aneurysm repair by Dr. Clay Whiskey with senior author Dr. Karan from Columbia University, New York.
Good evening. I'll be presenting a study on the impact of diabetes and in particular insulin dependence on long-term outcomes following AAA repair. Sorry, I missed the disclosure slide, but I have no relevant disclosures. So the protective effect of diabetes on AAA growth has been well documented over the past several decades, and namely, diabetes is thought to slow the growth of AAAs. The vascular surgery literature includes very little data about the impact of diabetes or insulin dependence in particular on mortality or long-term outcomes. We did find a couple of studies, and in particular, there's some data in carotid endarterectomy that suggests that insulin-dependent diabetes raises perioperative outcomes or complications to an unacceptable level. However, the study did not evaluate long-term outcomes. So to our knowledge, there has not been any study on the influence of diabetes on long-term outcomes following aneurysm repair. Part of the inspiration for the study actually came from the orthopedic surgery literature, which demonstrated that insulin-dependent diabetes in particular is associated with worse perioperative outcomes and long-term mortality. So we used the VISION database, which, as you've heard a couple times earlier this weekend, links VQI data to long-term Medicare claims data, thus offering more complete follow-up on mortality and reinterventions than the VQI database alone. So we examined three groups. The first was non-diabetics, the second was diabetics who were not insulin-dependent, and the third was insulin-dependent diabetics. And we basically had two analyses of these groups. The first was to look at all diabetics versus non-diabetics, and the second was to look at insulin-dependent diabetics versus all others. The reason for this approach was that we wanted to better sort of delineate the effect of insulin dependence from diabetes in general. So our primary endpoints were perioperative mortality, as well as mortality at 1, 3, and 5 years. We also looked at freedom from reintervention at those same long-term intervals. Our secondary endpoints included perioperative morbidity, ICU length of stay, and the cost of reintervention. So we drew nearly 40,000 patients from the VISION databases for open and endovascular AAA repair. And after we had excluded patients with missing diabetes status, small aneurysms, prior aortic aneurysm repair, and also Medicare Advantage patients, we had a total of 22,000 patients in our analysis. And the reason for excluding Medicare Advantage patients is that their follow-up can be incomplete in a lot of cases. So we focused on the Medicare fee-for-service patients who had much higher rates of consistent follow-up. So of those, we had of those 22,000, about 18,000 had an EVAR and about 3,000 had an open repair. And there was a slightly higher rate of diabetes in the EVAR group compared to the open group, and this was statistically significant. So moving on to baseline characteristics, in the open repair group, there was a higher rate of large aneurysms among non-diabetics. So those are aneurysms greater than 7 centimeters is how we define that. Generally speaking, there were also more comorbidities, not surprisingly, among diabetics than non-diabetics. And looking specifically at insulin dependence, much of the same trends held true. Those who were insulin dependent had higher rates of other comorbidities as well, and these comorbidities were ultimately adjusted for in our multivariate analysis. Our initial analysis was looking at perioperative outcomes, and on this slide, as well as on subsequent ones, we have perioperative outcomes for open repair on the left and EVAR on the right. This slide compares all diabetics to non-diabetics, and we found that diabetes was not associated with a change in perioperative mortality. It was, however, associated with a higher rate of postoperative MI and postoperative dialysis following open repair. It was also associated with a greater rate of 30-day readmission and MI following EVAR. Here we've got raw perioperative outcomes for the insulin-dependent group versus all others. So insulin dependence was associated with higher day readmission for both open and EVAR, as well as higher post-op MI for EVAR. Of note, there was no difference in perioperative mortality. And just as a note, you'll see certain columns are omitted. This is because the vision database policy requires us to censor patient numbers and percentages in groups with less than 11 patients. However, we're still able to do statistical analyses and odds ratios. We're just not allowed to display those numbers. So then we looked at long-term outcomes, and specifically at mortality at 1, 3, and 5 years. So diabetic patients had no statistical differences in mortality at these intervals for either EVAR or open repair. In other words, diabetics as a whole behaved similarly to non-diabetics in the long run, at least in terms of mortality. You'll notice that long-term mortality is overall higher in the EVAR than the open repair group, which we attributed to selection bias, and the total rates of aneurysm-related death were actually equivalent between these two groups. In our Kaplan-Meier analysis, you can see that diabetes did not have a significant impact on long-term mortality. And now looking at insulin-dependent diabetics, so these patients, on the other hand, had a significantly higher rate of long-term mortality following aneurysm repair compared to all others. And we presume that these were mostly due to diabetes-related complications, since the total rate of aneurysm-related death was similar between the two groups. One of the most surprising results to us was the high rate of mortality among insulin-dependent diabetics, even at the 1-year interval, which was 15%, compared to 9% for all others. We did a sub-analysis that just looked at elective aneurysm repair in order to make sure that we weren't seeing some confounding effect from ruptures, and the numbers were essentially unchanged in that analysis. So as you can see in the Kaplan-Meier curves, insulin-dependent diabetes was associated with an early and sustained increase in long-term mortality. Switching over to our multivariate analysis, so while diabetes in general wasn't associated with higher long-term mortality in the raw outcomes, in our adjusted analysis, it conferred a slightly higher long-term mortality with odds ratios, or hazards ratios, in fact, ranging from about 1.1 to 1.3. In our multivariate analysis comparing insulin-dependent diabetics to all others, the impact on mortality was much stronger and statistically significant across the board. As I mentioned, we also looked at the frequency and cost of reintervention and found that insulin-dependent diabetes was associated with higher rates of reintervention and about a 50% increase in the cost of reintervention at 1 year. And this trend was sustained as we looked out at 3 and 5 years. So in summary, our key results were that perioperative mortality did not differ based on diabetes status. There were, however, differences in long-term outcomes, including a significantly higher rate of mortality for insulin-dependent diabetics compared to all others. And these differences held up in our multivariate analysis. So in brief, non-insulin dependent diabetics largely behaved similarly to non-diabetics, but insulin dependence conferred a much higher long-term mortality. So these findings raised questions about whether insulin-dependent diabetics should have a higher size threshold for prophylactic repair. Thank you very much.
Thanks, Clay, for bringing this to the meeting. This obviously contradicts some of the, the evidence that metformin can sort of inhibit SAC growth, and I think multiple groups have looked into post-EVAR whether SAC regression is, altered by being on metformin. Could you tell from this data set other medications to treat diabetes, and did you have enough granularity to see about whether the mortality signal that you have here was related to SAC changes or not?
Yeah, it's a good question. Well, one of the things that we were actually most excited about looking at initially was the rate of SAC regression based on diabetes status. And unfortunately, the completeness of the long-term imaging data simply isn't there in order to perform that analysis. We did not have, unfortunately, data on specific medications that the patients were on either.
Great presentation. Was there any difference between type 1 and type 2 insulin-dependent diabetics?
We didn't have that level of granularity either, unfortunately, but we did look at age in particular as maybe a proxy, assuming that the patients who were on insulin with a younger age might behave differently. There simply weren't enough patients who were young, insulin dependent, and getting EVARs to draw any significant conclusions there.
Really interesting data, and I'm sorry if I missed it. The reintervention concept is really interesting when talking about diabetes. Did you have a sense, because the cost was higher, did you have a sense that they were undergoing more complex reinterventions, or was the cost difference just the difference of taking care of a diabetic patient overnight in the hospital as opposed to a non-diabetic patient?
Yeah, good question. The differences in cost seem to parallel the differences in the total number of reinterventions. So we couldn't conclude that there were any more complex reinterventions in one group versus the other. It was simply a higher rate of reintervention that was driving those differences in cost.
Hey, Lizzie George from Stanford, really nicely presented. Two quick questions. I haven't had the privilege of working with VQI Vision yet. Are you able to get a sense of how well controlled these patients are in terms of their diabetes?
No, we didn't have enough A1C data, unfortunately, to draw any conclusions there.
And then do you have any sense of what the natural history of patients with insulin-dependent diabetes is in terms of their sort of 5-year mortality, just to kind of compare it to a baseline to see what potentially this intervention did to altering their natural history?
Yeah, I mean, that's a great question. I think that's the biggest question that this study raises, because we don't have good natural history data of these patients, because that would require them to forego the generally accepted repair. So we don't really know what insulin dependence or diabetes does on aneurysm growth rates or rates of rupture for patients who meet criteria for aneurysm repair.
Thank you. Nice work.
Thanks.
Great. Thank you. Nice presentation.
Thanks.